When you encounter an unconscious patient, the pressure to find an immediate diagnosis is intense. You have to suppress that impulse. Before you investigate the cause of the coma, you have strict structural priorities. You always assume a cervical spine fracture. Secure a patent airway while maintaining rigid C-spine precautions. A, B, and C always come first. This flowchart maps the standard decision tree for the comatose patient. You check glucose levels first. If the patient is hypoglycemic, the standard adult protocol is to administer 50 cc's of D50W intravenously, but you have to look for the clinical exception. If the patient appears malnourished or has a history of severe alcohol use, giving that glucose load first is dangerous. You must administer 100 milligrams of intravenous thiamine before giving glucose. Doing this out of order can precipitate Wernicke's encephalopathy, risking permanent coma. You also need to manage potential toxic ingestions. Naloxone is given at 2 milligrams intravenously for opiate overdoses. Flumazenil is available for benzodiazepine overdoses, but you must be certain it is a pure exposure. If the patient ingested a mix of other drugs, pushing flumazenil can easily induce seizures. Adhering strictly to these sequential steps prevents you from causing irreversible brain damage with intuitive but ultimately incorrect early interventions. Let's apply this to a complex case. Paramedics bring in a 50-year-old man found unconscious in a downtown park. The responding medics report he is comatose, with a total Glasgow Coma Scale, or GCS, of 7. This table breaks down the Glasgow Coma Scale into 3 specific responses. For his eye-opening response, the patient receives 1 point for having no eye-opening. Under verbal response, he scores 2 points for making only incomprehensible sounds. For the motor response category, he exhibits nonspecific withdrawal movements from painful stimuli. That gives him 4 points, bringing his total score to 7. Looking at the bottom classification, any score between 3 and 8 points firmly categorizes this as a severe brain injury. This low score dictates an immediate, aggressive trauma response from your team. The physical environment around the patient is high context. His clothes smell of alcohol, his pants are urine-stained, and his jacket holds an empty wine bottle alongside a recently filled prescription of phenytoin capsules. It is easy to synthesize these observations into a likely clinical picture: severe alcohol intoxication, a withdrawal episode, or a post-ictal state following a seizure. But a systematic physical exam reveals contradictory details. The patient has numerous healed scars and encrusted sutures on his right scalp. Furthermore, his right pupil is dilated to 6 millimeters and does not react to light, while the left is 3 millimeters and reactive. Look at this abbreviated differential list. Based on the asymmetrical pupils and scalp trauma, identify the most critical life-threatening condition. The answer is an intracranial hemorrhage or hematoma. Pupil asymmetry is a critical localizing sign. It points directly to brainstem compromise and active herniation. The empty wine bottle and soiled clothes create a convincing but misleading narrative. If a clinician assumes this is just an alcoholic stupor and lets the patient sleep it off, the outcome is fatal. Relying on the superficial story of the scene, rather than executing a strict neurological exam, traps you in a fatal anchoring bias. We can contrast that acute structural crisis with non-emergent conditions that masquerade as systemic physical failure. Consider Joe. He is a 47-year-old veteran with a 20-year history in the armed forces, including multiple high-stress deployments. Joe doesn't present with acute trauma. Instead, he reports feeling physically sick most of the time. He complains of severe muscle tension, unexplained sweating, stomach upsets, diarrhea, and relentless, snowballing worries about his family and finances. To diagnose generalized anxiety disorder, you map these symptoms against specific clinical criteria. The patient must experience excessive worry for 6 months or more, find it difficult to function, and exhibit at least 3 somatic symptoms, like sleep disruption, fatigue, or muscle pain. Joe meets all of these criteria. The dividing line between Joe's chronic illness and the man in the park is structural. Psychiatric conditions cause profound systemic distress, but they completely lack acute, localizing neurological deficits. Joe does not have a blown pupil or a depressed coma scale. Managing altered mental status requires discipline. You secure the airway and C-spine first. You quantify the deficit using the Glasgow Coma Scale. You sequence thiamine before glucose to prevent Wernicke's.
And you actively hunt for localizing signs to break through your own anchoring bias.